Call to order the stroke committee for GTECH. I've done a roll just to save time. Is Salvador here? No. Homer and Joanna can't be here today. Everybody else is here. We're going to go out of order a little bit because of a time conflict. I have asked the Pediatric Stroke Work Group, Charles Macias, and I blocked on your name, Kate, to talk to us and answer some questions about pediatric strokes. And so let's start with that, please.
Okay, so thank you for the opportunity to chat a little about pediatric stroke. I want to begin by saying that we're not really a formal work group. This is really a discussion, and I guess in as much as we consider this to be an important area where there is a paucity of evidence and a paucity of definitive strategies in the world of pediatric disease management, it is a critical one for us. But one of the things to understand in the world of pediatrics is that the etiologies are very different than they are in the adult world. And while some of the strategies that we have for management of children are fairly set by our consultants, even the people who manage the disease, even the people who follow up in consultation for rehabilitative therapy really exist primarily in the pediatric specialty world. I say all that to say that we are taking something with a prevalence of 2 in 100,000 children, and it gives you a sense of why we have such few registries, so little evidence, so many different etiologies, and such unclear pathways for what to do in this realm. Consequently, there aren't a lot of national registries. There are some academic institutions who have attempted to establish some of these. There is some information sharing, but it's very challenging for institutions or even regions with that low a prevalence to even develop some commonality in the approaches that they take. But there are a few things that make it unique. So with that as the setting, I'm going to leave that open for you to begin whatever questions you have that help clarify the role of stroke management in children.
So I'll start out. Are there different scales? I mean, we're probably, GTECH is dealing with acute intervention in the truck, trying to transport people to the appropriate place. Is there anything different for the first responders that they need to do in regards to pediatric patients in assessment of stroke?
So there aren't any validated pre-hospital stroke scales specifically for pediatrics. There's the Pediatric NIH Stroke Scale that's been used, but that's an extensive assessment that wouldn't really be well adopted for the pre-hospital setting. You could assume that any of the adult stroke scales could be adopted or adapted to the pediatric population, but there's no validation of that. If you look at the stroke scales that are out there, when you look at the Peds NIH Stroke Scale versus the adult, there are a lot of similarities there, and so that's why I think you could potentially use CPSS or LAPS or whichever stroke scale is your preference. The challenge in kids is that there are some processes that could potentially mimic a stroke. One in particular is something called TOTS paralysis, which sometimes after a seizure, kids can have a transient period where they're not able to move one part or all parts of their body, depending on, so they can have some what look like apparent motor deficits that may not in fact be a stroke at all. But has to do with the seizure activity. So in terms of assessing for stroke in the pediatric population, it is going to be rare, and I would say any child who has sudden onset of neurodeficits that could be potentially picked up using one of the adult scales, you might make the assumption that there is a potential stroke there and they would require further evaluation by a pediatric specialist.
And if I could add one thing to that, so in most, if not, in many, if not most, children's hospital, even the application of the NIH Stroke Scale is actually conducted by pediatric neurologists. So even as a PZM physician operating the ED, the definitive assessment is actually by pediatric neurologists. So it really shifts the diagnostics and even the discussion for imaging, whether it's going to be DWI, MRI, or any subsequent type diagnostic imaging, into hands primarily driven by the pediatric neurologist. And that's primarily because of the rarity of the event. So that makes it even more challenging to take those kinds of scores that are validated even within a subspecialty consultant group into the pre-hospital arena.
So do you have recommendations in regards to transport? For example, up to what age would be one thing to think about. But also, I mean, most people that are going to be driving ambulances, they're going to be preferentially wanting to go to children's hospitals. Are there situations where they should stop, not bypass? Are there things that you would recommend within the transportation of these patients?
Yeah, because pediatric stroke is such a different beast, there aren't, the AHA stroke guidelines don't particularly speak to them, and so early therapy with thrombolytics is not, the goal. There are so many different etiologies, whether that be infection or arteriovenous malformation that's bled, or a mass, et cetera, and so even trying to figure out what type of stroke these children have had and why becomes a challenge. I would say that any child who has new onset neurologic deficits, you would want to be seen in a pediatric capable facility. Now, again, because of the potential that it could be confused with things like top paralysis, do you want to be immediately, flying these children 300 miles away to only find out once they get there that they're not actually having a stroke and they're fine and they can go back home? That seems to be a questionable use of resources, and so we have to be careful there. But I think if you can identify those pediatric capable facilities within a community, then those patients can be transported to those facilities, which is a little bit of a separate discussion that we're actually having among some of the other committees, which is how do we identify pediatric ready facilities from those that are not, and at least to have the capability of staff that when a child gets there, they know what to do with them. They know how to get them transferred to the right facility quickly and efficiently, and make sure that they have the imaging capabilities that are necessary for these types of children. I don't know if there was another part of that question that I'm not yet answering.
Yeah, are there situations where you would stop and you wouldn't bypass an adult hospital to go to a pediatric center?
Yeah, I guess, to his point, if you had suspicion that it's probably not a stroke, so if you really think that this is more likely a TOTS paralysis based on the history, then that might be reason to go to one of the closer facilities. Although I would still argue you'd want a pediatric capable facility. But there's not, we're not talking about respiratory failure, you're not talking about cardiac arrest and the immediate need to get into a hospital setting where you have more resources. So really the goal here is going to be early identification of a stroke if it's truly happening, which is going to require usually higher levels of imaging than are readily available at most community hospitals. They have to be able to sedate a child potentially for an MRI. Do they have those sedation capabilities? Do they have a pediatric anesthesiologist available to do that? Do they have the diffusion-weighted MRI or perfusion scans and pediatric radiologists that can read those? So it becomes much more complicated in terms of making the diagnosis. And I don't see, I wouldn't suspect that there would be a reason in an acute stroke patient to stop at one of the adult facilities for acute intervention.
So in the pediatric population, about 30% of kids that present with stroke of any etiology are otherwise healthy. And that makes sense because most of the diagnoses that we are labeled with as adults present for the first time sometime in childhood. So in many of these cases, that is the first time some of these comorbid conditions are presenting. That makes the diagnosis very complex. And also makes it much more likely that a child is going to present out of the first 6-hour window of when symptoms first occur. Consequently, if you look at prognosticators or prognostic factors that determine good outcomes, they're really related to tying them in to the right early rehab resources, which means being in with a pediatric neurologist, a pediatric PM&R. OT is a very significant part of that, speech therapy, social work, integration, and all of the social networking that is very different than the otherwise very articulate adult who can fend and describe for themselves. And then there's the whole bit of family services. So those kinds of things never really exist in critical access hospitals to the degree that they're really needed in the pediatric population, which is really the biggest argument to say, if really in doubt and you don't think there's a really high risk of this being TODS paralysis, and you're really not just trying to be safe about it, you really think this is that event, it's just always safer to go to a tertiary or quaternary children's hospital.
The other question you had asked was about age. And to that end, to what Dr. Macias was just speaking to, if you look at subspecialists in pediatrics, generally speaking, 18 is their cutoff. And so any child under the age of 18 would be followed by these pediatric subspecialists. And at usually around the 18 to 21 year age range is when we would generally try to transition them to adult subspecialists. And so if you were going to choose a cutoff, that would probably be the most likely cutoff that you would choose.
So you got a question, George?
I guess my comment would be, in some ways, the stroke transport and evaluation is in a lot of ways patterned after the trauma triage system and so forth. And so I agree with you, the pediatric population is very different. I'm not sure in some ways it's even more difficult to answer that question across the board for the state of Texas of where to take those people initially. As an example, kids particularly can present with neurological deficits that have an unknown trauma history. They got hit in the head with a baseball or bat or whatever. And so I think, and I'm not saying I'm making a recommendation, but I'm just saying, so there's a whole different, as you said, population of etiologies, if you will, for these kids. And so we're back to this issue of rural versus urban settings. And I think the first thing is to get them assessed radiographically in some way, and then get them to the appropriate tertiary care, pediatric center, trauma, or stroke center. So I think that's something to keep in mind. But I do think to look at this is going to be important, just like they do in the trauma for kids. Look at this. And then my last comment is, once again, in trauma, they don't look at them by age. They would look at secondary sexual characteristics. So, I mean, you can have a 12-year-old boy that's like 22. So I think that's the other thing. But again, I think this also goes back to each area having their own triage and transport system in place, and initially getting the patient evaluated.
So to that end, if I can speak to taking them to a hospital where they can initially evaluate them, we know from a large national assessment on pediatric readiness within emergency departments to care for medical illnesses in children that there are enormous gaps that exist. And so this is a slightly separate discussion, but what we're trying to bring to many of the other GTECH committees right now is the idea of identifying those hospitals that are pediatric ready, and that would facilitate some of this so that you know where those pediatric capable facilities are within a community so that you could potentially bring those children there rather than just any community hospital.
Right.
And again, it's to bolster those communities, not to take them to, a children's hospital.
I would add surgical as well as medical treatment.
Yes, absolutely, absolutely.
It's good. Other questions? Anyone? Well, I would certainly, I know you guys are working on pediatric-ready hospitals and those statuses, and we want to invite you to, help us help you, in regards to this stuff. And so as you come up with stuff, please come back and let us know. And if there are things we can do to help you, same thing, please ask.
Well, I think it would be helpful in terms of that. If we do want to make sure that we can send children to hospitals within the community that are ready, then would the committee also support in concept the idea of pediatric recognition, where we can identify those facilities for our EMS systems?
Yeah, please bring that back to us. I think it would be favorably received.
We're asking for committees to support the idea and concept without an actual implementation plan, because we know that's going to require the input of numerous stakeholders whom we've already begun discussions with, but that will, the how is further down the road, and really this is the concept of pediatric recognition.
Sure. I mean, a quick straw poll is, anyone have concerns? No, so we agree to that.
Wonderful. Thank you very much.
All right. So thank you. Next up on our agenda, and some of these work groups may not have stuff to do or stuff to present, but the first is the Stroke Education Program Work Group. And HT can't be here, but Deb's here. Can you tell us some of the stuff you've done or where you're at? I know the website's down, so.
Yeah, okay, so right now we're just trying to gather what kind of resources are out there for EMS, nursing, physician, whatever, for stroke, for education, because we know that we all need so many hours of it. So Homer has put together a list so far of 11 different websites. A lot of those are national, but there's also a lot of local things going on at the different RACs and things because of the Comprehensive Center. So there's a lot of educational opportunities. So I guess the question is, I mean, we can gather a lot of information, we can gather a lot of like the brochures and that kind of stuff, but then where are we going to post it and how is it going to be maintained? Those are a couple things we're going to need to try to figure out. I mean, like the Texas Nursing, the Stroke Coordinator Forum, that's one place that for nursing that we could post. And I'm sure that there's other EMS websites as well, but it's just trying to figure out the best way to do that. So I think that's where we're at right now.
That's cool. Any other thoughts from other committee members?
Does EMS have like a national website of, somewhere that these could be posted, since a lot of these are for the newly EMS stroke education? Does anyone know? I'll look and see if I can find that.
I mean, we do have a GTECH. We will have a GTECH website at some point.
Hey, Dr. Rutledge,
Sir.
I think there are an enormous number of activities going on, and I think what you're saying about getting them all published in the same spot makes a lot of sense. I think there will be people at the state level and legislators quite impressed with all the things being done to educate the public about stroke. In addition to the continued need to educate the public about stroke, since most are coming in personal vehicles and after a lengthy delay and even seeking care. So I like the idea a lot.
Okay, well, we'll explore that. Next up is the transport bypass work group. George, do you have any new things to add?
Not yet.
Not yet. Well, we're going to have Paul talk to us in a few minutes, and that may change. And then Johanna, who's not here, is head honchoing the data work group. And I'm sorry to say that right now we haven't had a chance to finish reviewing the applications for stroke-ready hospitals. We were reviewing those as compared to the Brain Attack Coalition guidelines, and we hope to have that for the next meeting. Also, that work group is working on looking at data points in the NIMSIS registry to pass on to the Texas Council on Cardiovascular Disease and the DSHS in regards to which elements we think are key. Joanna asked if there was any one of our members that might help her. There's a lot of work right now, and if anybody wants to volunteer. Okay. Okay. Because there's like 4 people that we have to compare to the BAC and then looking at the NIMSIS data. Okay.
We've actually started already doing some of that. So we haven't stopped gathering.
Great. So we're on time. This is good. So next up is update from the Texas Council of Cardiovascular Disease and Stroke. And we met last Saturday. And the newest thing from the council is we just gave a conference in regards to stroke survivors and caregivers. So the council it works on heart disease and stroke and has many different organizations that feed into them. One of the excellent ones is the partnership, Texas Cardiovascular Disease Partnership. And what they do, and I guess I don't want to overtalk some of the members that are here, is they're working on prevention, hypertension, diabetes, cholesterol, and things like that. And it represents, I think, 250 organizations, DSHS and all, and many other groups to try and help prevent disease, which is usually the most cost effective. So the council is going to work with the partnership to try to put on a conference with them, similar to this stroke survivors, which is sort of remediation after a stroke. And then GTECH, we're focused more on the acute care of stroke and heart disease. So that's what the council's working on right now. And in addition to that, I have a bit of a report from the council in regards to the Rider 67 and collecting the data through rack-centric means. This has proved to be very good because we're getting a lot more hospitals involved in providing this data where we weren't as effective before. Let me go through, I'm trying to get the exact numbers, but it's about like, let's see, benchmark participation was like 15 hospitals for heart attack and 5 for stroke, 32 hospitals for both. And currently, that's increased to heart attack for 26 hospitals and stroke 26 hospitals and 172 hospitals for both. So that's a significant, so the RACs have made a significant increase in collecting that data as we move forward. As you guys remember, this is a vendor-neutral request for data. That is, going through a specific vendor is a long, involved process for the state to do. And not only is it a long, involved process, people have different opinions and different needs on a local level for which data vendor and how they collect data. So from our standpoint, from the state's standpoint, what we want is the data, and then the vendors can fight it out and the RACs can choose the best vendors. And there's some really excellent ones out there. Let's see, also from the council, and the other thing I would say, we got a request from the Office of Acquired Brain Injury. They're forming a Texas Brain Injury Advisory Council, and they're requesting a member of this stroke committee from GTECH to be on that council. And I wanted to see if there was anyone interested here in doing that. No? I stare while someone wanted.
Who is this again?
This is the Office of Acquired Brain Injury. They're forming a Texas Brain Injury Advisory Council. And they're looking for, they want a member, membership is defined on this council, and one of the members they want is someone from our GTECH Stroke Committee as one of their members. You want to do it? Okay, I will pass that on.
Could you send me some information on who that is? I'm just
You can pass that down to him, he can look at it as well.
Didn't they just have a conference, not like, I think they just had a conference back in April about brain injury and how to deal with it and stuff. I think it was in Tiger.
I got a question.
They gave a presentation. Remember at our last meeting,
Yeah.
they gave a presentation. Or stood up and said something.
Okay. Well, one of us will do it, Paul, or maybe you could share, depending on the date. So next up is actually an incredible project from the University of Texas at Houston, who's done some stroke center mapping. And what we're going to do is I've asked them to, I've got to see these slides and they're incredible, and tell us, I think, a lot about our state and looking at gap analysis and what we're all about. And so Dr. Wu is going to present the data for his group.
Thank you for allowing us to share our project. I'm Teddy Wu from UT Houston. I'm presenting this on the behalf of the NonStroke Stroke Consortium. Our project it's a very preliminary project that's looking at stroke research disparities throughout Texas. It was a mapping project that was thought about when we started looking at the different stroke centers throughout the state where there were opportunities to do stroke research, and we felt like there was just a lack of an inventory of where stroke research is actually happening throughout the state. So that's kind of where this project was born from. Our objective in this survey project was to gain the understanding of the status of stroke research among all the stroke centers that were designated on the designated stroke centers on the DISH's website, which is about 136, if I'm not mistaken. Also to examine the volume of stroke discharges throughout all of the hospitals throughout the state that were not designated as stroke centers. These were the components of our survey. We, number one, confirmed their stroke center status and which accrediting organization, whether that was DNB or JACO, whether they had resources such as a dedicated stroke coordinator, whether they were affiliated with a comprehensive stroke center, whether they referred patients to a comprehensive stroke center, whether they were involved in telestroke, and most importantly, were they already doing stroke research, and if so, what type of stroke research projects are they actively involved in. In addition, we coupled that with stroke discharge data that we got from DISH's. When this project was undertaken, we had stroke volume discharges from all of 2013. We were missing the last quarter of 2014, so we had to use the 2013 data for our project. Our methods, so we obtained a list of the level 1, 2, 3 stroke centers from the DISH's website. There were 136 total. We obtained the contact list from the rack with all the coordinator names, the phone numbers, and the addresses of all these 136 facilities. We initiated the survey by calling each facility at least once, and including with email. We contact them at least once by phone, at least once by email. One refused to participate, and in total, 109 out of the 136 responded to our survey. This is just kind of the flow of the methods of how we obtain the survey. I don't think it's really that important. We just asked those questions that I went over earlier. The stroke discharge data was for the non-stroke facilities were obtained from the Center of Health Statistics from Department of State Health Services. Population data was the 2010 census tracts obtained from the U.S. Census Bureau. and you'll be able to see all the maps that we were able to generate. So I know this is a pretty busy slide. It kind of highlighted the things that were important. So in all, there were 136 total facilities that were designated a stroke center. 80% of them responded, so 109 out of 136. Importantly, 90% of the primary stroke centers, since there was only 13 comprehensive stroke centers, 90% of the primary stroke centers were JCO certified, as opposed to 10% of the primary stroke centers that were DNV certified. A majority, so over 80% of the primary stroke centers actually had a dedicated stroke coordinator, so they had some resources in that respect. However, 20% didn't have anybody that was designated for that position. 67% out of the 110 primary stroke centers were affiliated with a comprehensive stroke center facilities, and about 50-50. So 50% of the primary stroke centers out there had telestroke and 50% didn't. And the most importantly was that, as you can see, the comprehensive stroke centers, so 13 comprehensive stroke centers throughout the state, they're all doing research. That's actually by definition. You have to have that done. Unfortunately, 67 hospitals out of the 110, so almost 80% of the primary stroke centers out there are not involved in stroke research at all, out of the ones that responded. And those are the ones we kind of really wanted to focus on. Stroke discharges, so coupling that with the discharge with stroke volumes, if you look at the highlighted panels, we wanted to focus on facilities that were not designated as stroke centers that had high volumes of stroke discharges. So we actually found that if you look at hospitals with over 150 stroke discharges per year, there were still 21 hospitals out there that were discharging high volumes of strokes that, at least in 2013, were not designated as stroke centers. And we felt like that was an opportunity to kind of intervene, whether they should become stroke centers or they need to be involved in stroke research, since they have the stroke volume to support that. So as you guys can see in the map here, these are all the stroke facilities throughout the state. If you can see, majority of all the stroke centers are located in the metropolitan counties, Dallas County, Harris County, Travis County, and Behar County. So all around the big cities, although there are obviously a couple spread throughout West Texas and South Texas. These are all the stroke facilities that are doing research. You can see, if I kind of flip back and forth, they're all in the same areas, in the same 4 counties that we went over. A few spread out, but definitely the facilities that are in the big metropolitan areas are the ones that are doing research. Telestroke, again, if you look at all these 3 maps, Telestroke also concentrated around those same 4 counties. It's not well used of resources in my mind. There should be probably more stroke centers out there that are using Telestroke, but this is what that map is telling us. So I think most importantly, if you look at this map, this is mapping of the population around non-stroke facilities greater than 50 stroke discharges. So the different color H's are the number of stroke discharges, 50 to 89, 90 to 138, and the red H's are the ones that are greater than 139 discharges. If you look at the range here, there was actually a hospital that was not designated as a stroke center that discharged 681 stroke patients in 2013. So again, extraordinarily high numbers, but they weren't designated as stroke center at that time. So I think we went over this already. So this is kind of the crux of what we wanted to answer. Are there stroke facilities out there, or non-stroke center facilities out there that had high levels of stroke discharges that we could potentially collaborate with to get them involved in doing stroke research? Do they have a lot of stroke patients, and what type of studies could they do, and what type of resources do they have? And as you can see, there are ones out there that there are major populations that are deprived of being involved in stroke research. Stroke center, telestroke facilities and research. Again, a lot of the stroke research centers are in the same areas in which telestroke is being deployed. Our summary for our very preliminary study, again, a high number of primary stroke centers not doing stroke research, although having a dedicated stroke coordinator, meaning that they have some basic resources. About 40% of them are using Telestroke, and 84% of the primary stroke centers have greater than 150 stroke discharges. There are stroke centers, non-stroke centers out there that have high levels of stroke discharges. I think this is probably the key slide. Most of the stroke research is being conducted in the 4 major markets that have existing comprehensive stroke centers. So if you add up the total population in those 4 to 5 counties, we have about 40% of the Texas population residing in those 4 major markets. And that seems quite large, and they're definitely covering a lot of area there, but they're over 50% or almost 60% of the population that is not in that area that, number one, they either don't have a comprehensive stroke center or they're deprived of being involved in stroke research. So it's definitely a lot of room for improvement from a research standpoint. Future direction. So as part of the Lone Star Stroke Consortium, and our goal is to conduct stroke research throughout the state and to collaborate with as many hospitals as possible. A potential use for this information that we gathered was to approach primary stroke centers to seek participation if they're not doing stroke research already. We felt that since 50% of them are using telemedicine, we potentially can use that and leverage telemedicine as a resource. Most facilities that use telemedicine have academic centers that provide the telestroke service that may have a little bit more experience in doing research. They'd be able to reach out and provide resources that way. And they definitely have the volume, and with stroke coordinators, potentially the resources available. They may be those really, really good sites that we can deploy interventional-based trials. So how can we increase access to stroke research? We felt that we can approach the non-stroke centers with high volumes to participate in stroke research, maybe those less labor-intensive trials, observational trials, natural history trials, because they may not have the resources to do so. And we're also working on a mapping project regarding disparities to stroke research in proportion to the population. We understand there's a lot of limitations to our study. Stroke discharge data is based on 2013 data. We cannot account for changes in designation and status at that time, so maybe they were a stroke center in 2013. Somehow in 2016 they got knocked off the list. Maybe things change. We did not call non-stroke centers. They may be already doing stroke research, and they may be part of a comprehensive stroke center, health system, or network, and we definitely need to tease those out. So that's it. Thank you for your time. I'll take any questions or comments.
Well, I mean, obviously this is outstanding. That's why I invited you. It's you know, a neat snapshot, and I think, you know, from a Texas Council of Cardiovascular Disease and Stroke, we're obviously looking at gaps in stroke care, and then that is where the rubber meets the road, is where the transport systems then in acute care get people to the right places. So, I mean, I really applaud you. I think this is really cool.
Thank you.
You guys have questions? George?
Is this published anywhere?
We will be publishing this. We're working on drafting a manuscript for this and submitting this also as an abstract to the next stroke conference. We have not seen anybody publish anything on stroke research and disparities, and we thought this was very, very important in getting this information out there.
Dr. Wu, there may be RACs that are very interested in this data. They may not be aware of hospitals that are having a high volume of stroke patients, and the RAC could in fact go out and maybe offer some support for those hospitals to become primary centers or more. But the information's been lacking. So can a RAC contact you for their particular area to say, what hospitals did you identify in my region that maybe we should reach out to?
Absolutely. I think we're more than happy to work with anybody that this information would be beneficial for. We are working along with DISHES as well to see how our projects with the Lone Star can provide them maybe a more microscopic level picture of what's going on the ground. So we're more than happy to share anything with anybody that's interested.
If it's okay, I can share your slides with
Sure.
the other councilmen, but
I think I've emailed it to you yesterday.
right, but I need your permission to
Yep.
do that. Yep.
So are you saying we could put this up on our soon-to-be functioning website?
Well, I think we can certainly discuss that. I mean, the first thing, I mean, we should distribute the slides. I mean, I think this is really great information. And Mark Alberts, who I hope I've made an offer to him to come to our next meeting, is also doing a similar project, but looking at more a gap assessment of where there are strokes versus where the stroke hospitals in the state, which is actually mirrors this map, but it's a little bit different in that it's telling you where you need a stroke center versus where their strokes are and opportunities for research. So they're sort of similar but different. Other questions? Yes.
Yeah, I think for the non-stroke centers, there's going to be a lot of issues related to just the resources to be able to, number one, the resources, to be able to participate in the research, and then number two, even knowing what to do. So would there be any consideration of trying to get like a pool of people that could help them? Help somebody, or even like through the Lone Star have maybe a person that would be able to go and help them set up?
I think that's a great question. The way Lone Star was set up was that we would provide resources for them, whether that's training, whether that's paying for a research nurse at those facilities. One of the projects that we did at one of our, albeit it was a primary stroke center, was an interventional trial in which we helped them with IRB. We have on-the-ground training. We enrolled more patients in an interventional stroke trial that was acutely linked to TPA at our telemedicine site than at our own hospital because we had too many studies that were competing. So we definitely have the resources to help. And with telemedicine, we can do a lot over telemedicine. We're able to consent the patient over telemedicine, get them to sign the paperwork, help them get transferred and all those things. So I think leveraging technology to enhance research is definitely a huge thing that we're looking forward to in Lone Star.
Other questions? These are all good. Thank you very, very much.
Thank you. Thank you for having me.
Next up is going to be Paul Hansen, and their group has been working on looking at first responder field assessment tools. Obviously, we have to have the tools to then do the transport, and we're very lucky in Texas that we have a three-tiered system with the comprehensive centers, which are doing interventional, the primary, and then the support stroke facilities. So I think this is germane to moving forward with all of those.
Thank you. So I put together a handful of slides here, really just to describe what the currently available validated triaging tools are for predicting stroke. So why do we need this? So again, this is something that we've been talking about for quite some time now. So interventional therapy has been widely accepted to be the next step in stroke treatment. So one step beyond just TPA by itself. But the idea is we need to be able to identify which patients are going to be that are going to most benefit from these next steps in therapy. The AHA guidelines that were updated and rewritten here earlier this past year are recommending getting treatment to these patients within 6 hours. So there's a very small window to make sure that we're getting patients from the field to the appropriate sites. We know that there's a concomitant reduction in mortality when we're getting to these patients quickly. Escape showed us that it was about 50% drop in mortality alone. But we also know that there's a 7% reduction in the benefits of our therapies every hour that this therapy is delayed. The NIH Stroke Scale is validated for predicting a large vessel occlusion. The cutoff is 10, so an NIH Stroke Scale score of 10 or higher is correlated with an LVO. But the NIH Stroke Scale is not a practical study to be doing in the field, in the back of an ambulance by EMTs. It's just there are too many steps, too many parts. It takes too long, and I don't think we would get reliable scores. So the next step is what sort of field triage scores can we use in order to identify these large vessel occlusions, with the idea being that we can then, if needed, bypass primary stroke centers to go directly to comprehensive stroke centers in certain settings in order to treat these patients appropriately. What do we need? We need something that's simple, reliable, quick, essentially an EKG for the brain, if you will, that will help identify those patients that are at the highest risk for having large vessel occlusion. There's essentially 4 tests that have been validated. That would be the 3-item stroke scale, the Los Angeles Motor Score, which was a subset of LAPS, RACE, the TSI pre-hospital score, or LEGS. And then there's another one in development in Houston that I haven't seen enough data suggesting that it's been validated, but it seems like it's a pretty good score, so we'll have to keep an eye on that. You may ask, why is there no Cincinnati Stroke Scale score and those sorts of things? It's because those scales are actually geared just towards identifying, is it a stroke or not? And that's step 1. We want to know, is it a stroke or not? But beyond that, we need to know, is it a specific subtype of a stroke or a large vessel occlusion, so that they would benefit from endovascular therapy. Next. So we'll just look at these briefly. So the 3-item stroke scale score was developed specifically to identify MCA strokes, nothing else. It's a shortened NIH Stroke Scale. Basically involves lateral gaze, level of consciousness, motor function. So it's a 6-point scale with a number greater than or equal to 5 correlating to a large vessel occlusion. And this is basically just the rubric of how that is scored. It's pretty simple, pretty straightforward. They're all portions of the NIH Stroke Scale, so they're pretty easy to teach how they're scored. And that's really it. You may ask, though, if you have to get 5 out of 6 points, how specific can it be? And we'll get to those numbers towards the end of this. Next. So the Los Angeles or the LA Motor Score. It came from the LAPS, which is the LA pre-hospital stroke scale. It includes a little bit more, so it's going more into arm strength, facial grip strength, but it doesn't have anything like aphasia or anything that's identifying specifically cortical signs. It's a 10-point score, and an LA motor score greater than or equal to 4 correlates with a large vessel occlusion. And this is just a picture, again, of the rubric of that one. And again, it's a very simple, straightforward scale, and it's pretty reliable. And again, we'll get to those numbers at the end when we compare all of them head-to-head. Next. So RACE is a score developed in Barcelona. Again, I know it's been pushed a little bit here. It's a great score as well. It's a little bit longer than the other pre-hospital triaging scales. It includes facial palsy, arm motor function, leg motor function, gaze, aphasia, and agnosia. The issue with this one is that sometimes it's difficult, even getting highly trained people, to recognize the difference between aphasia, dysarthria, and trying to suss out aphasia, dysarthria, agnosia in the field may be a little bit more than people are going to want to deal with. It has been validated in the field, and that was done in a study in Barcelona, Spain. However, they used TCD data and not CT or MRA data in order to identify the large vessel occlusions, so there's some question of how sensitive that test is. Okay. And here's the Spanish version, but basically it's arm, leg, face, strength, eye, gaze, and then the bottom 2 boxes are aphasia and agnosia, and you score each side separately. And so that's how you get to 18 points total, 9 for each side. Next. So that one's cut off a little bit at the top, but this is the TSI pre-hospital scale. This is something that's been developed and presented at multiple conferences, has yet to be published, but was presented at the International Stroke Trial in 2013 and 2014, as well as SVIN and a couple other trials, or a couple other conferences. Again, it's an abbreviated NIH Stroke Scale score, so it makes it easy to teach. Deals with leg strength, eye movement to either side, vision, and speech. So 16 total points. And again, it's a cutoff of 5, or maybe my slide is cut off. Yeah. Cutoff of 5 or greater that correlates with a large vessel occlusion. Next. All right, so that's the picture of how that one works. And again, it's specifically taken directly out of the NIH Stroke Scale, so it's things that are pretty easy to teach and pretty easy to score. Next. So this compares all of those numbers side to side. It's kind of a boring slide, but what it looks at is the main trial used to validate the score, so that's the sample size, then the sensitivity and specificity of the scale, positive predictive value, negative predictive value, and the positive log ratio, which is whether or not it conforms, how well does the curve represent the actual data. So what we see is they're actually all fairly similar. As far as sensitivity, race and the LA motor score are slightly higher than the other ones, so you're going to miss less strokes that way. Specificity, so is it actually identifying a stroke, or is it non-specific? Is it pick up other things? The best scores there again are the LA motor score and the legs, and 3ISS is actually pretty specific as well. And so when you look at all these numbers and you put them side by side, there really isn't one trial that's head and shoulders above the others. And so what we've talked about is what is the best way to choose one of these to use in the field. And it's hard to make a sweeping generalization that we should get behind just one of them. But I think that simplicity is going to be the most important thing here, because we're talking about teaching a large number of people with varying medical backgrounds to do a study under not ideal circumstances. So that's what a field score is. And probably the simpler scores are going to be the better scores, because we're not looking to be right on every single case. We just want to be right on the vast majority of cases. So when you look at all of these together, the LA motor score probably stands out as maybe the easiest to do. But otherwise, I think they're all pretty similar. So this is something where you can either let the RACs decide which one that they want to adopt, so that everybody's speaking the same language. I think the worst thing that can happen is that everybody uses a different scale, and then nobody can talk to each other about them because people aren't familiar with the scales that are being used.
So, excellent. And when you're talking about the sensitivity, we're talking about sensitivity to large vessel occlusion, not just a stroke.
Correct. So that's, these are, in these studies, these are patients that are already known to have strokes, and so it's going back and seeing, do these triage scales reliably predict if it's a large vessel occlusion versus, say, a Lacuna stroke or something else.
Right. So the corollary is large vessel occlusions are better treated endovascularly with better success rate, and so better transported to comprehensive stroke centers.
Yep.
So other questions? This is great. So are you willing to share these slides that we could send them, and I'll send them out to all the people on the council here on this committee?
Give them.
There's another question. Did you have a question, George? You were looking.
Well, I mean, when we've looked at the different racks, and again, different places have different politics and use different scoring systems. And there's not a clear-cut favorite. And so there may even be the argument on the other side of saying, well, let's divide it up and use some different scoring systems in different areas and see how we hold up. Again, this is important to give us some, I think, guidelines for the EMS and the pre-hospital initiation of treatment. But then ultimately, us making decisions about the triage criteria for bypassing goes to the next level as well, where you've got to see what you're dealing with, whether it's a lead or a large vessel occlusion, etc. So I think for all the RACs to have an opportunity to look at this, and then maybe we can get some feedback from them, which would be helpful for us. to make a recommendation in that way, but, you know, my comment is just that. I think you can look at it both ways, so.
Or if I can summarize, bottom up rather than a top down strategy may be more effective. And so you're requesting feedback from the RACs in regards to what they found works best, maybe medical directors and stuff, and differentiating large vessel occlusions from regular strokes.
So if we're able to post this up and then send it out to the RACs and give us some feedback, and then we can actually find out what everybody is doing and tally that. Who knows, we may be already doing, everybody's using a very similar triage score.
I agree with that, and I think every RAC should have a program in place. I can tell you at SETRAC, it was a lengthy process, and we had probably 70 physicians in a room. And this included neurologists and ER doctors and neurosurgeons and EMS medical directors. And it was a pretty difficult process, and it was worthwhile. And we ended up with a spin on, I guess, the LA scale. That it was spun because we have some peculiarities with time of day to be able to reach some of these facilities, and just some hardships that EMS must factor in. But in the identification of the patient, it's very clear in our protocols as to when you have a patient that should be going to a comprehensive center as a result of the use of the protocols. It's now being studied and proofed up factually. I think every RAC should have a process in place to help the EMS agencies, but we do need to be careful about requiring a particular tool. Thank you.
Yeah, I think we're not requiring, we're acting as a resource for the RACs so that they have, you know, have information that they can go forward with. And then also, depending on the RAC, I mean, if you're, you know, a RAC without a primary stroke center, you're going to have a very different transport plan than a place that has 3 or 4 to choose from, all within 5-10 minutes of each other. Other comments to Paul or thoughts? You guys are planning to publish this, or this is in process to be published?
There's a manuscript being written currently, so I expect it'll be published this year.
Well, I mean, obviously an area in evolution, and we'll just keep, I mean, that's why we have our work groups, and we'll keep working on it. And in that regard, if there are RAC members that have thoughts or about this, please bring this to the stroke education work group or the transport work group, and we'll try to help get that information. Yes, you're the transport work group. So Fillingham is the education, and Kevin is the Kravitz is the transport. Okay, so moving on, we're on time. So next up is review and discuss the revisions of the Texas Department of State Health Services stroke rules in Title 25 of the Texas Administrative Code, TAC, Chapter 157. So as you guys know, the Department of State Health Services, I think, has done a really great job of vetting suggestions on rule changes. This committee has worked on that as well, and we've made our suggestions as well. I think it's important for everyone to understand that these are suggestions to the DSHS, and that we may not all get what we want. Part and parcel of that, we also have gotten things that we wanted. This committee voted on Brain Attack Coalition as the means of looking at certifying bodies, and that moved through the GTECH Council and is actually what's gone forward in the way we're looking at designating, certifying bodies. And that's what's ongoing right now in our review of the ASRH, the DNV, and the CIHQ, and their new requests using the Brain Attack Coalition's requirements. But when I was looking at, the proposed rule changes, one of the ones that sort of bothered me a little bit, and I thought we might discuss it. You can't hear me? Okay. Well, one of the rules, possible rule changes that concerned me, not necessarily which way the rule was going to go, but it was that the suggestions have been pretty much 50-50 on which way to do it. And anytime you have, people who are like 50-50 on doing the rule one way or another, that really doesn't, what we really want is more of a consensus. And what that rule was on moving the designation process to 3 years versus the current 2-year cycle in the rule. And so I wanted to go over some of this and bring it up for discussion so that we might be able to help the DSHS, or I guess just to have a big fight here all over again. So right now, in certification, the Joint Commission certifies on a 2-year cycle, whereas the DNV, HVAP, CIHQ are 3 years for the different certifications. Now, in regards to the number of facilities that are approved, we have 98 facilities that are under Joint Commission that are being certified every 2 years. And then for the facilities being certified every 3 years is 18. And so, I can't predict the future of who's going to be the dominant certifying agency, Joint Commission, or others. And that's a very personal choice. But I'd be interested in what people think. Traumas every 3 years. A lot of people are on a 2-year cycle. So stirring up the mud, what do you guys think? Please.
So one of the issues that have come up with the Joint Commission is they get so far behind. So for example, for us, when we were due to be certified last summer, we were 9 months late. So in order to do the every other year, then we're constantly asking for extensions from the state. So I think that was part of the discussion when we were in the actual rules, working through it. That's one of the reasons, I think, behind why that was brought up in the first place. I don't know.
That's a good reason. Other thoughts?
I just have a comment specifically regarding DNV. It is a 3-year certification, but they do come annually and visit, and so even though you're recertified every 3 years, it is an annual visit. So that wouldn't necessarily be an issue. If you were needing a survey report, you would get one annually from DNV.
So is anybody who's a Joint Commission person and being certified every 2 years, is it onerous to be designated every 3? Is this not as controversial as the voting suggested?
There's a couple other considerations. One is the cost for a lot of these places. And I guess I would try to say this politically correct. How many de-designations have you seen occur by either Joint Commission or DNV? Where someone's stroke certification is, oh, you've lost your interventionist. Oh, you've lost your neurosurgeon. Oh, you don't have ICU capabilities. And so there's a different level of accountability, I think. So we have cost, We have looking at the 2 certification entities that we're talking about. So as you said, to muddy the water a little bit, just to throw out a counter comment. So I don't know the answer to those questions, and I would be curious to know.
I mean, the reason I brought it up is it's been controversial and brought around, and as it's currently slated right now is to change it to 3 years, but that was a very slim margin that passed it, so go ahead.
Dr. Rutledge, can we do a clarification?
Sure.
Designation is what is done by DSHS.
Right.
And the application is only $100 every 2 years. So I would just like to clarify that so that there's a difference between cost of certification and designation is only $100 every 2 years.
And would it be, so moving to 3 years, would it still be $100 or $150?
33 years.
Yeah.
I don't know.
That's it. So, are there any public comments that people want to make on 2 years versus 3?
I have a question.
Yes.
So as a joint commission, thank you so much. Just for clarity, as a comprehensive joint commission certified hospital, would we still be on a 3-year cycle for certification even though our joint commission's every 2 years?
No, we're talking about state. So the organizations certify you, and then you apply for designation from the state.
So this is strictly...
This is talking Texas.
Designation only. Okay.
And that designation then is what allows the hospitals to become part of the transport plan by the RAC.
So the certification every 2 years would not interfere with the designation status, even though it wouldn't be in sync?
That's correct.
Okay, thank you.
But the DNV is
3 years. Certification.
So we're back to the same. So you're going to have hospitals, as they said, that are joint commission that file for an extension that are 9 months to a year out that really have had no review. So I mean, there's some issues within the designation and certification process, and before we even get to talking about certification by the state.
And what I would propose is we're trying to encourage people to become stroke centers. We're trying to encourage, the better care of stroke patients rather than being, did you have a CT tech come in an hour late last night? That's not the purpose of this. You want to try to help people to do better, not the other way. Not a punitive approach. So, yes, you have a comment, please.
Hi, my name is Brenda with TTAP. I would just like to comment that in many, many hospitals, the stroke coordinators wear multiple hats and have to perform multiple functions. For them to have to go through a survey designation process every 2 years is very challenging for them. To add that 3rd year might make the difference in whether or not they're able to maintain their program and to be successful with their survey. And I just want to make one more comment. If joint is 9 months behind, then they're already just certifying every 3 years. So we might as well look at that 3 years a little closer.
So if I'm reading this right, then this is not as controversial as was suggested by voting, that 3 years is, no one's really upset about going to a 3-year designated cycle. This is your chance. Okay, it doesn't appear to be as controversial as DSHS was worried about. So Suzanne, do you want to say anything about the rules? Any comments or things that I left out on the process of this process of going forward? We're going to put out some rules as it's been revised here in the near future. You don't want to say anything. Are there any other things that I should have added to the
I don't think
discussion?
so. I think you did well, Dr. Rutledge. And the only thing that I do want to say about the stroke rules is, and my apologies, in February, I thought that we were going to be able to start up again on the stakeholder meetings for the stroke rules and the revision. The unfortunate thing is that we are still 5 people down in our department, and neonatal rules is kind of consuming our lives because that is the new program that is rolling out. We do hope that we will be able to get stroke revision rules out at some time, but honestly, I am not going to say when that will happen because I was evidently very positive in February and it just did not happen. So we will send out a notification when we do get ready to put the stroke rules out again for another stakeholder meeting.
Thank you. Okay, so next up is general public comment. Anyone have something to say? Come on up.
Good afternoon. I'm Randy Crutching with the Department of State Health Services. I just wanted to give a brief update to the Rider 67 data collection initiative to kind of tack on to what Dr. Rutledge had mentioned earlier. Currently in the state of Texas, 53% of eligible hospitals are participating with our project compared to 12% back in August of 2015 when we had our benchmark date. So we've had a significant increase there. 41% of hospitals located in rural counties are participating compared to 59% in the urban counties.
Say that again.
We're at 41% of hospitals located in the rural counties are participating compared to 59% in urban counties. New hospital recruitment materials have been developed to highlight the options that hospitals have for participation. Prioritized outreach is expected to begin later this month, so we can target the rest of those hospitals. With our project, our collaborative met April 26th. A representative from each of the 7 stakeholder groups makes up the membership. That was our initial meeting with that, so we're very excited about that. Project manuals were shared with the collaborative members and will be posted to our Rider 67 webpage when the website comes back up. And then planning for regional system of care improvement activities is underway. So that's just a very brief update on where we are with the Rider project.
But before you go, can I put you on the spot?
Yes.
So what is the deal with the website? Or what's your personal understanding? What's the deal?
Very
It's being
limited.
rebuilt?
I have very limited knowledge on what's happening with that based off of what our IT department is sending us. Basically, they're updating each page of the DSHS webpage, and so that's a fairly extensive project, and I'm not exactly sure when the projected completion date is.
It crashed, it's reconstruction, it's a project improvement?
I believe it's project improvement, but I'm not 100% sure on that. I know that there are efforts to take individual pages and make them available as they get those reconstructed, so it'll be coming up in a stepwise fashion.
One of the things I think is really interesting is it shows how much people are actually using the website, that it's like people are complaining and that it's down. It's like,
They were.
pardon?
They were using it.
Yeah, but I mean, obviously, this may have been used more than people thought, that this is, that this really is a resource. And so, but yeah, we'll bring somebody up and they can beat on it. We can beat on them for IT issues. Let's see. Something. Oh, so in regards to this data, I can go back to the council's point of view. What we hope to do is have data come back, at least, and this is from the previous rider, because we still have that data coming in, but the idea is to try to get that data to the RACs by this summer. That then allows the RACs to actually lobby their own legislators and use that data to try to improve processes. So at least that's our goal, is to try to have some information for the RACs this summer. That does put you on the spot.
Thank you. Yes, we have talked to our OSER team about the proposed timeline for analysis of the data and when we can have those reports out. And so
interim report.
Yes.
Yeah. Cool. Other questions for him?
I really enjoyed the report, the statistics. Thank you. Will the RACs learn what hospitals are not yet participating?
We are in discussions to see what we are allowed to share based on the language of the rider on who is and is not participating. What we currently are able to do is to release a list of eligible hospitals in each RAC so that they have a target list to look at. And then we can then supplement that with the hospitals that submitted through the RAC data collection tool. So there will have to be some weeding out on the RAC's part to figure out which hospitals are still need to be targeted.
Okay. So guys, it would sure be nicer, easier if we could just get a list of what hospitals need a phone call so that we can encourage those hospitals to submit their data. But what he's saying is he may not be allowed to because of legal reasons?
It may be due to the verbiage in the contract. So we have posed the question to CMU, and they're taking it to legal to see what information we are able to provide. Obviously, being able to say, here's your target list would be a perfect case scenario.
Yeah.
But at this point, I'm not in a position to be able to say when that's going to happen. That has to go up through legal still.
Okay. Thank you.
Some of this is a definition of what is. I mean, the idea is from a hospital status, many want to be anonymous. And I think we have to respect that. I mean, right. I can understand that. I mean, I think public information comes out anyway, and that, you know, it's hard to really be anonymous. But whether you participate or not, does that fall within anonymity? I think that's the legal question that they're struggling with.
I understand, and as a hospital administrator, I understand. Meanwhile, we've got patients to think about, and so thank you.
Anything else?
Yeah. Or give out a sticker for everyone that submitted.
Other public comments?
Yes.
I have just a topic for your thought. We were talking about all of the patients that are now being, with the large vessel occlusions, being the rapid transport, the drip and ship patients, seeing an increase in that, and the transporting from one center to another. So, for example, how many areas have critical care ambulances versus a regular ambulance? And are the EMS providers comfortable with a patient who's being transported with actual TPA dripping maybe, and then with the 2-hour issue with the angioedema, the complications that can occur? So it's just some discussion that we have talked about. So I think it's something for us to consider between the transport committee as well as the education committee. I just think it's a consideration. The ability for the EMS to transport and their level of comfort, I guess, and expertise.
Maybe that could be a topic we could put at the CBD symposium that the CBD council is talking about, if that would be appropriate here. I was just, Dr. Rutledge, you had mentioned the CBD council was thinking about putting on some type of seminar or symposium, am I correct?
With the stroke partnership.
Okay.
And what their what the partnership does is look at things to prevent stroke. So that's hypertension and things like that. I think your question falls more within GTECH, which is the acute care. And I think Deb's idea, pass that on to the Education Committee and the Transport Committee to look at that, I think is very reasonable.
So then we're back to getting feedback from the different RAC directors. What do they have in place? I mean, helicopter transportation capabilities, or is it just by land? And so we would need to send a questionnaire out to the different RACs and see what we have.
Yeah, just a quick monkey survey would work.
That's because you're right, but at the same time, I shouldn't assume, but you would think they would have something in place already.
So I want to invite any other people on this committee have topics that they want to bring up. And no more public comments? Any other public comments? If not, so to summarize our GTECH meeting report, I want to apologize to the ASRH, the DMV, the CIHQ. We are acutely aware of the commercial and financial implications of not finishing the gap analysis if you need the BAC requirements, and we will work diligently on that to have that for the next meeting to try to expedite that for you. I'm also going to move forward to see about website space for the resources that we're putting together. I think that is absolutely the whole purpose of this committee, is to act as a resource for the first responders, for the medical directors, and for the RACs. So I can't think of a more appropriate use of the website. And if we can't do one website, we can find a way to do another website. And then obviously we need to bring forward to the General Counsel just the information that we've gleaned today from Paul and Teddy, both excellent reports. Anything else that you guys think we should move forward to Council? Seeing none. I don't have a review or list for next meeting, but Lisa may have some information on some software that we'll talk about. Next meeting date is in August at the regular time, unless there's conflicts you guys want to change. Hearing none, that's it. This meeting's adjourned. Thank you guys very much for coming. We all appreciate your help.